Hi and welcome to this video brought to you by the Society of Mechanical Ventilation, Esophageal Balloon Manometry.
Hello everyone, today we'll talk about the esophageal balloon manometry. We'll talk about the esophageal balloon and pleural pressure and transpulmonary pressure. We'll review those. We'll talk a little bit about how to insert it and interpret the information or the pressures that we're getting, what some of the pitfalls of this technology, and what some clinical information and benefits we get. Of course, it's a very old technology but very beneficial, and in my opinion, we should use it much more. Of course, it's a very long discussion, long talk, so we'll try to be brief as much as possible. Some brief description of the esophageal balloon here. As you can see it, this is one of many balloons available in the market. Basically, back in 1949, it was shown that it's possible to use esophageal pressure as surrogate for pleural pressure. And back in the 50s, they showed that the pleural and esophageal pressure were similar and could be used to understand respiratory mechanics. And 1955, it was shown that the changes in the pleural pressure was similar to changes in the esophageal pressure, although the absolute values of the pressures were not exactly the same, and the pleural pressure was negative. So how are we going to insert this balloon? The one that we're talking about is 86 centimeter with 9 centimeter balloon. You need a 3cc syringe, an extension tube, 3-way, and what we're going to do, you can insert it from the nose or from the mouth. Usually we'll try to go into the stomach, so we insert it down to 50-60 centimeter in the stomach, and when you push in the stomach, the deflection, you would in the left upper quadrant, you should see deflection, so you know that you're in the stomach. We'll inflate the balloon by 3 cc's of air, then we'll withdraw 2, and of course all that time is connected to the ventilator. Once we put the balloon in and we see cardiac oscillation and we think that we are in a good position, now how do we know for sure that it's reflecting our pleural pressure? So if the patient has spontaneous breathing, what we have to do is an expiratory pause. As you can see here, inspiration, and then we put an expiratory pause. The patient will try to breathe in. You see the dip in the airway pressure, but against an occluded valve, so there is no breath, and you can see the esophageal pressure is going down in parallel to the airway pressure. If they're almost similar, or usually 0.8 change in the esophageal. Okay, so what are we really measuring with the esophageal balloon, or whatever measurements that we have? Of course, we know that the airway opening pressure, that's the airway pressure. We have here the alveolar pressure, which is basically the inspiratory pressure when you put a pause during inhalation, or the plateau pressure, or the end expiratory pressure, or the PEEP when you put an expiratory pause. So that's the alveolar pressure. So we have the airway pressure, the body surface area or barometric pressure outside, and the airway, alveolar pressure. What's missing is that pleural pressure, and of course we cannot measure the. So some things to consider when using the esophageal balloons. I here put it under problems or pitfalls. As we said before, the esophageal pressure might not be the exact same value as the pleural pressure, but at least it parallels it, whether it's negative or positive. The absolute value of the esophageal pressure can be influenced by many things, like the respiratory mechanics, the lung volumes, the weight of the mediastinum, of course the abdomen, the posture, reactivity of the esophageal smooth muscles, and sometimes actually you can see spasms in the esophagus, the mechanical properties of the balloon, increased abdominal. So let's talk a little bit about the benefits of the esophageal balloon. And once I start talking about here, you will notice that I'm very biased. I really love this technology and I use it a lot. Of course, I'm not gonna lie and say that I use it on every single patient on mechanical ventilation for many reasons. Not all the ventilators I work with has a port for the esophageal balloon measurement. Although I have to say, when I was a resident and fellow, I saw my mentors using this separate device, which measures only the esophageal pressure, and then you have to print them or try to. So again, the transpulmonary pressure is basically the airway pressure, whether during end of inspiration or end of exhalation, minus the esophageal pressure, again as a surrogate of the pleural pressure. So in this picture, we have in yellow the airway pressure. This is patient of pressure control mode. We have that esophageal pressure, and you can see the cardiac oscillations. That looks like a passive patient. So, excuse me, the esophageal pressure goes up or during inhalation, and the transpulmonary pressure displayed here is basically airway pressure minus esophageal pressure. In this simulator, we'll talk about how to measure the end inspiratory transpulmonary pressure and the end expiratory transpulmonary pressure, like we talked in the previous slide. So if you look on the top here, the yellow is the airway pressure, pink is the flow, this orange one is the esophageal pressure, and because it's a simulator, of course, you don't see the cardiac oscillations. This is passive patient, so you don't see the drop in the airway pressure of the esophageal pressure if the patient is making an effort, and the sum of the airway pressure minus esophageal pressure will be the transpulmonary pressure. So in this case, to measure the end inspiratory pressure, we're going to put an inspiratory hold, just a couple of seconds, and here the airway pressure here is about 25. The pleural pressure or the esophageal pressure is about 15, and the transpulmonary pressure will be end inspiratory transpulmonary pressure will be 25 minus 15, which is like about 10. And usually the recommended is about 10, 12, 14, depending on the case, of course. How about the end expiratory transpulmonary pressure? So the same, but we're gonna do an expiratory hold. And again, we set the PEEP at 5, so the airway pressure at 5, the pleural pressure or the esophageal pressure is 13.5, so the difference would be transpulmonary pressure of minus 8. And that's one of the methods to set the PEEP. So I'm going to increase the PEEP here to 15, and the idea is to keep that end expiratory transpulmonary pressure somewhere between 0 to 5, and the idea is to prevent alveolar collapse at the end. So in this case here, if we do another quick expiratory pause, here now our transpulmonary pressure is about, end expiratory is about 0.8. The other thing one of the importance of the esophageal balloon is we all talk about the driving pressure and the airway driving pressure, and you can tell this patient is having 20 of inspiratory pressure over 15 of PEEP. So the peak airway pressure is 36, but the driving pressure will be basically the pressure that we set here, especially the end inspiratory, the flow goes to 0. So he's on driving pressure of 20. And to measure the transpulmonary driving pressure will be the same. So we'll go here from the end inspiratory, which is, I want to say it's about 18, and the end expiratory is like 0.5. So the transpulmonary driving pressure is about 17.5. So that's how we measure the different transpulmonary pressures. I usually like to talk about this study we did a couple of years ago. about the benefit of transpulmonary pressure in APRV. We all know that APRV is very long inspiratory pressure time high and very low time low. One of the problems is we have no idea what's really the auto peep, and we depend on auto peep, but we have no idea what the auto peep is. So using the esophageal balloon here, and we put an expiratory pause. So here's the end, the auto peep after with an expiratory pause, and again. So nowadays, mechanical power is a very hot topic in mechanical ventilation since Gattinoni mentioned it in 2016, and since then there's so many studies about mechanical power, and that's not the topic of our discussion right now, but I want to talk about the transpulmonary mechanical power because I think that this is more relevant to lung damage and ventilator-induced lung injury than just the whole mechanical power. We all know that there is many different formulas and calculations to calculate the mechanical power depending on the mode. There's still debate. Now for the next couple of slides, we'll be talking about the compliance, how to calculate the compliance or the elastance, because we all know compliance is 1 over elastance, or elastance is 1 over compliance. How to calculate the compliance of the whole respiratory system, how to differentiate it into chest wall and lung. So if you look at this graph, it's very famous. This is the compliance of the whole respiratory system here in the solid purple line, and it's, if you differentiate it, it has 2 components: the chest wall, more to the left, and the lung is here, because we know that the lung, again, similar graph here. This is the whole compliance of the respiratory system. I will show it to you in the simulator, and again we can differentiate them into chest wall compliance and lung compliance. Usually the chest wall is very linear, but the lung one looks like the whole respiratory system. But you can see this to the right, this to the left, they give you that whole graph here. Okay, so we'll back to our lung simulator, and we'll talk about how to measure the things that we just talked about total respiratory compliance, chest wall compliance, and the respiratory and the lung compliance separately. So we'll have to do a pressure volume curve, quasi-static. In the Hamilton ventilator, all what you have to do is go to PV tool, and you start. If you have another ventilator, you have to go to a volume controlled mode with a square flow, constant flow, and very low flow, about 5-6 liters per minute, and do it. So we're going to do the setting. I would start from 0 of PEEP, and we'll end at 0 of PEEP. We'll go to the slowest ramp speed here, 2 centimeters. We'll put a little bit pause, 5 seconds, so the whole maneuver will take 40 seconds. So we're gonna go ahead and start. And again, this is the airway pressure, this is the tidal volume, and here the ventilator is about, the pressure is going up, as you can see here, very slow, and it's plotting the graph from 0 of PEEP. You can see here area of bad compliance, then all of a sudden good linear compliance. That's a patient with ARDS. And it starts here, that's a pause there, which is basically considered a recruitment maneuver. It's 40 centimeter, and exhalation starts, so it will show in the curve here for a second. Okay, here we go. So as you can see, this was in the pictures that we saw before. Even the ventilator tell you where is the low inflection point here at about 15, the upper inflection point, and that's a pause, and we can see that the patient gained good tidal volume. You can see the big hysteresis here between at 20 centimeter. If you do the cursor at 20, you can see that there is a large tidal volume, more than a liter here. So this lung looks like recruitable. Anyway, we talked about the pressure volume curve before in another video, the first one of the videos about respiratory mechanics. So the interesting things here, so this is the airway pressure against the volume, so that's a compliance of the whole respiratory system. What we can do is we'll specify it into esophageal pressure versus volume, and that will give you the compliance of the chest wall, and as you can see, linear here during inspiration. So you can calculate the compliance of the chest wall, and most importantly, we can plot the transpulmonary pressure versus the volume, and that will give us the lung compliance by itself. So of course, as you can see, it's shifted to the left. Here again, low inflection point. So this is the lung compliance itself. Then we'll talk about how to calculate each component by itself, although you can cheat in the ventilator here. The more you move the cursor, it will tell you what's the compliance of the lung when you do the transpulmonary pressure, what's the compliance of the chest wall, and what's the compliance of the whole respiratory system. But we'll try again to do it ourselves in the next slide. Okay, so this is, I know it's kind of a busy slide, but we published this before to put the equations and make it easier for people to calculate, and I usually give it to a lot of the students, respiratory students, to the residents, and I tell them, okay, calculate for me all those numbers, and I can tell you that less than 1% do it. But anyway, I'll put the reference for this. It's just only 2 pages at the end of the video. So this is a patient quickly on the volume controlled mode. You can see that's the airway pressure, looks like a triangle with a constant square flow. He's a passive patient, not having any effort. Okay, we talked in the video about putting a pause on the recruitment maneuver using the pressure volume curve as a recruitment maneuver. Here again we did the pressure volume curve, and we're plotting the transpulmonary pressure to the volume, and the difference in the airway pressure, usually we go to 40 centimeter. Here we try to go 25 centimeter of the transpulmonary pressure, and as you can see, when we put the pause, you gained big volume here, so that tells you that the lung is recruitable. And I think I know there's a lot of debate about whether should we do recruitment maneuvers or not, or are they useful or not. I think one of the other benefits of the esophageal balloon is monitoring is patient effort, and this is just a graph to show the effort. So the first one, number A here, this is the flow in pink, the airway pressure in blue, esophageal pressure in green, and the transpulmonary pressure in black. You can see that this is a passive patient because there's no negative deflection before the airway pressure. You can see here it's at baseline esophageal pressure, and once the machine gives the breath, there is a positive deflection up of the esophageal pressure, as you can see here. Compare this to an active. Another benefit of the esophageal balloon is calculating the work of breathing and the P muscle, or the muscle pressure created by the inspiratory muscles called PMUS. Now this is not one of my favorite calculation slides because it's kind of difficult math a little bit. We all know that Campbell diagram. Inspiration starts here and expiration starts here, and that's esophageal pressure versus the volume, and that's a static chest wall compliance. So we can see why it's difficult. Okay, this is the the paper I was talking about. To the left here is the esophageal pressure and the tidal volume, and this is the chest wall compliance that we talked about before. And again, now patient spontaneously breathing. Here's inspiration and here's expiration. And the red area is the work of breathing. So again, the integral of the chest wall relaxed pressure minus the esophageal pressure multiplied by volume. So you can, in this example here, the change of tidal volume, which is about, I think. All right, another thing, the esophageal balloon can help us in patient-ventilator interaction and dysynchronies. So there's some lot of graphs here. Let's go to this left side picture first. This is the airway flow. This is esophageal pressure. I'm sorry, this is the airway pressure. This is the esophageal pressure, and this is the flow. You can tell that this is a spontaneously breathing patient on mechanical ventilation. And why? Because esophageal pressure goes down more negative than compared to the end of exhalation. And you can see the airway pressure here. There's some negative deflection, so you can tell that the patient. Okay, another reason to have an esophageal balloon and its importance in during weaning of mechanical ventilation. As we talked before, if you're really worried about how much work the patient is doing, you need an esophageal balloon to calculate the work of breathing. The pressure time product also, there's airway pressure time product and esophageal pressure time product. And I don't think I mentioned it when we were talking about the PMOS and the work of breathing, but as it implies, it's drop in the esophageal pressure times the time, and that also gives you a. Now we talked about the transvascular or the transmural pressures and the filling pressures of the heart. Usually when we measure the central venous pressure or the left ventricular end diastolic pressure, which is the pulmonary artery occlusion pressure, we always assume that's all what's inside the pressures inside the heart. We forget that there is a pressure pushing from outside the heart. And there's not many studies about this. We found a couple of studies and I tried to implement them. So this one example, the pressures here is 100. Okay, this is some of the references that I was talking about. I would really recommend those two first articles. This one is from 2014 in the American Journal of Respiratory Critical Care and talks in details about the things that we've been talking about it. And this is a newer article from 2020 in Respiratory Care. Again, those in general talk about esophageal pressure and the pleural pressure and all the benefits. This is an article from 2020, talks about the transpulmonary driving pressure and the transpulmonary mechanical power we talked about. This is an article from our Journal of Mechanical Ventilation and talks about how to calculate the respiratory mechanics, lung mechanics, and chest wall separately. And this is another one calculating the work of breathing during mechanical ventilation. And this is one about the esophageal pressure balloon and the transpulmonary pressure in APRV. Again, there is a lot of more to talk about, and I probably missed some stuff, but otherwise the video is going to be very, very long and more boring than already is. So with this, I would say thank you for listening and sticking to the end. I hope that was beneficial, and I hope I convinced you of the benefits of using an esophageal balloon. Thank you again.